Good evening, everyone. Hopefully, audio video is okay. All right. So today we are going to discuss the FMGE medicine portion, and these are recall-based questions. So if there is any discrepancy or any change in the option or any values in the question, do let me know. So starting with question number 1, an elderly patient presented with focal seizures. CT scan shows multiple ring enhancing lesions in the brain. All the following can be immediately given in next 24 hours except. So the options are steroids, anti-edema measures, seizure control, and anti-helminthic treatment. So this multiple ring enhancing lesion could be the neurocystic sarcosis. So it is ring enhancing. So that means that there is some sort of inflammation which is going on. So yes, we will give steroids. That is true because it has the anti-edema property as well. Anti-edema measures like mannitol can be given here. Seizure control is also true. While anti-helminthic treatment in first 24 hours will aggravate the lesions to be ruptured, or it might cause the severe reaction. So therefore, the false statement here will be anti-helminthic treatment. That should not be given immediately. That is given usually after 2 to 3 days of controlling the seizures, controlling the edema. So answer here will be D option. Now coming to the next one. So the next question is question number 2. So question is, calcitonin is a marker of which malignancy? So all thyroid cancers are given. So it is a stat question. So answer here is medullary thyroid cancer. It releases the calcitonin, and that is also responsible for the secretory diarrhea in cases of medullary thyroid carcinoma. And in this paper, the majority of the question from the medicine come as a clinical case scenario which are asked. A less number of questions were just the one-liner questions like question number 2. Now, moving on to the question number 3, female 33-year-old is being evaluated for excessive daytime sleepiness and forgetfulness which have been present for the past 1 year. So whenever we think of excessive daytime sleepiness, the first thing which come in our mind will be obstructive sleep apnea. Immediately it will come our mind. But obstructive sleep apnea before the menopause or that age group is less common in women. Is less common in women premenopausal. Now let's see what are other parameters which are given. BMI is 43, which is putting her in a obese category. Blood pressure is also high, 170 by 98, and in the awake state, remember this is in a awake state. ABG shows hypoxia, which is 70 mm of mercury of oxygen, while CO2 is 53. Normal value is 40. Here is 53 which is given, and bicarbonate is on a higher side. So this is a case of a we can say acidosis, respiratory acidosis most likely. What is the cause here? So if we look at the first option, obesity hypoventilation syndrome. So hypoventilation means it applies that there is CO2 retention. So CO2 retention, hypoventilation is a reason for respiratory acidosis in a awake state. While obstructive sleep apnea, it will be only during the sleep that patient will have a decrease PaO2 or maybe increase in PaCO2. But in the awake state, the characteristic feature is normal level of carbon dioxide. So in the awake state, it does not cause the PaCO2 to be high. And also the BMI of 43 is pointing in favor of obesity, So the most likely cause here is obesity hypoventilation syndrome. So, central sleep apnea, this is not presentation here, typical presentation. And the narcolepsy will have a most important feature of the narcolepsy will be a decreased muscle tone or increased sleep duration, which should be given in the question. So, the answer is A option here. Now, moving on to the question number 4. So, question number 4 is, a 40-year-old lady presents with difficulty in eating due to persistent dry cough. She has dry eyes and dental caries is noted. What is the likely diagnosis? So this is clear cut. This is a stat question, though it is clinically given. It is a Sika syndrome, or we can say C option, Sjogren syndrome is the correct answer here. While mixed connective tissue might have a Sika syndrome, but other features of rheumatoid arthritis SLE, they will also be present in this scenario. Sarcoidosis as such does not present with dry eyes, it presents as uveitis. If eye manifestation is there, it is uveitis. Now the D option, vaginous. So the most important feature of the vaginous is the upper respiratory tract involvement. That should be given, like sinus or ear infections, that will be given, followed by cavities in the lungs, and C-ANCA antibody must have been mentioned here. So that is not the scenario. So option is C, the Sjogren syndrome. Now moving on to the question number 5. A 60-year-old bedridden patient develops a sudden onset of breathlessness and chest pain. Which investigation will be useful for screening the etiology of this presentation? So, if a bedridden patient develops a sudden onset of dyspnea, that means the most likely probability here will be a pulmonary embolism. So, this is most likely a pulmonary embolism. And the source of this pulmonary embolism in a bedridden patient, most likely source is D vein thrombus, most common source in bedridden patient. So in a pulmonary embolism, the screening test is always D dimer test, that will be elevated, D dimer, while the confirmatory test. So the confirmatory test, we will go for a pulmonary CT angio. So pulmonary CT angio will be the test. Yes, echocardiography will be done, but if there is a right ventricle dyskinesia, which is seen here, dyskinesia, then it will be a poor prognostic factor, poor prognosis, and that is known as a McConnell sign, RV dyskinesia. While when we do a Doppler of lower limbs, in 50% of the cases, it will turn out to be negative. This is a scenario in pulmonary embolism. In 50% cases, it will be negative. So for the screening, the sensitive test is a D dimer test, which should be done here. And once it is positive, then of course we should go for a CT pulmonary angiography. Now, coming to the question number 6. So as usual, this time many questions come on the CNS aspect, and in the CNS, stroke questions, 3-4 questions were on the stroke. So ABCD2 scoring include all of the following parameters. So ABCD scoring is determining the risk of the stroke. So this is for risk of full-fledged stroke after transient ischemic attack. After the transient ischemic attack. So in the emergency, we that score will give us a guidance कि we should keep the patient under observation. There will be more risk of getting the stroke later on if a TIA episode is there. So that include A. A stand for age. Age more than 60 years. That means कि high risk will be there. B is blood pressure elevation, like systolic BP more than 140, diastolic more than 90 blood pressure. C is clinical features. Clinical feature like speech impairment and weakness, and the weakness that is a clinical feature, unilateral weakness. While D stand for the duration. So the duration will be 10 to 59 minutes or more than or equal to 60 minutes. So more the duration of the TIA, then it will be a higher risk of the stroke. While D stand for diabetes mellitus. So D2. So these parameters are taken for a scoring of risk of stroke after the transient ischemic attack. So what is not being taken here? History of stroke means it is a risk factor for the stroke, not the history of stroke. So answer is C option here. Now coming to question number 7. Alright. So question is, a 50-year-old man presents with tremors along with the development of cognitive and emotional problem. Which of the following medical disorder is the likely diagnosis? So in a case of CNS, especially some sort of cognitive impairment is there or movement disorder is there, the important keyword in the question is the age. Look at the age. So 50-year-old is not a typical age of Alzheimer or the Parkinson. Remember the typical age, though there are case reports that can occur in middle age also, but we should go by a typical rule. So unlikely a Parkinson disease, unlikely an Alzheimer disease because of the age. The age of onset of these disorders is usually around 70 or more than 70 years. Now, patient has tremors along with the cognitive and emotional problems. So this is highly suggestive of the cognitive and emotional problems are highly suggestive of Huntington's chorea. While for Friedreich's ataxia, there should be some features of neuropathic features or ataxia features should be given to go in favor of Friedreich's ataxia, but these are not given here. So we will go for Huntington's chorea. D will be the likely answer here. Now, coming to the question number 8. So question number 8 is, which of the JVP finding is expected to be seen in a patient with muffled heart sounds and hypotension raised JVP? So the examiner have given indirect questions. They have not given the diagnosis key. In this diagnosis what should be the JVP finding. So it is a two-step solution of the answer. First step, what is the diagnosis? And second step, in that particular disease, what is the typical JVP finding? So patient has muffled heart sound, hypotension and raised JVP. This is a classical backstride. This is a classical backstride, and this backstride is seen in cardiac tamponade. So our diagnosis is cardiac tamponade. And those students who have attended the CVS class, there I always give you keywords in the question. So for cardiac tamponade, besides the backstride, there is another keyword. Another keyword means that particular sign has only one answer. And in cardiac tamponade, the keyword in JVP is absent Y descent. What is Y descent? Y descent is कि atrial blood move into the right ventricle during passive filling phase. But during the passive filling phase, right ventricle is collapsed due to a tamponade process. So when the right ventricle cavity is collapsed, blood will not enter into the right ventricle cavity. So there will be no Y descent. So this is the keyword for cardiac tamponade. So answer is B option. While absent X descent is seen in tricuspid regurgitation, A wave absent is a feature of atrial fibrillation. C wave large, again, it is a feature of tricuspid regurgitation. Now, coming to question number 9. A 50-year-old patient with lung cancer presents with breathlessness and lightheadedness. On lung auscultation, reduced intensity of the breath sounds are heard on the left infrascapular region. Diagnosis is, so patient has got a CA lung and now patient has breathlessness. So what can be the complications? So the complication here can be a cardiac tamponade. Yes, there is a possibility that cardiac tamponade is likely in cases of the CA lung. But in cardiac tamponade, what happens due to the pericardial effusion? Pericardial effusion, it causes the collapse of airway. And because of the collapse of the airway, the distal lung tissue becomes solid and we will find bronchial breath sounds. Rather than a decreased intensity of the sound, we will find bronchial breath sound at left infrascapular area. At left infrascapular area. So this is known as the Evart sign. Presence of bronchial breath sounds. So it is bronchial breath sound mean more transmission, good transmission of the sounds. So yes, this is a complication of C lung. Keep this in mind. But the feature of back triad and absent by descent should have been given here. Now pleural effusion. Pleural effusion, most common cause of malignant pleural effusion is CA lung. So it is also a complication. So in this case, pleural effusion, we will find stony dullness on the side of the effusion, as well as we will find here the reduced breath sounds. So this is more going in favor of our clinical scenario. Constrictive pericarditis is a chronic complication, so unlikely present in the CA lung, and pneumothorax, maybe it might cause the pneumothorax. CA lung can be a, but it is less common than the pleural effusions. Now coming to question number 10. There is no cardiac tamponade in the option. Okay, so if there is no cardiac tamponade in the option, even then you can understand the concept that CA lung can also cause cardiac tamponade. So our answer will not change. So any other option which was given there, not the cardiac tamponade. So what else was the option in place of tamponade? So we can discuss that and we can rule out that. Alright, so come to question number 10. A 23-year-old patient pneumonia. Okay, so in cases of pneumonia, yes, alright, so pneumonia, let's take pneumonia. So CA lung, especially the adenocarcinoma that is peripheral, might cause consolidations, So pneumonia is a consolidation, and in consolidation we get bronchial breath sounds. That means more transmission of the sound rather than reduction, more transmission. So that will also rule out the option. Yes. Now coming to question number 10. Question number 10 is 23-year-old patient presents with the history of flank pain, fatigue, history of red color urine. So patient has hematuria. So whenever a patient of hematuria comes to you, the most important test is the urine microscopy. So hematuria, dysmorphic RBCs, or isomorphic RBCs. Isomorphic means same size and shape. Dysmorphic means a different size and shape of the RBC. So this is due to glomerulonephritis, and this is due to non-glomerular causes. So non-glomerular causes like cancer, or can be a stone, or can be urinary tract infections, like that. So they will lead to the isomorphic RBCs. Isomorphic RBCs. So dullness was given in the option, yes. So if the dullness is given in the option, stony dullness or dullness is the same thing. So that effusion answer will not change. Option was post glomerulonephritis. No, there is nothing called as post glomerulonephritis. No, it is glomerulonephritis. What can be post written? Might be post streptococcal glomerulonephritis might be written, but answer will not change. It is glomerulonephritis because dysmorphic RBCs are given here. UTI, urinary bladder stone, it will produce a isomorphic RBC. Here dysmorphic RBCs are written. Minimal chain disease, there is no hematuria as such. So minimal chain disease will be characterized by proteinuria. Proteinuria, not the hematuria. So answer will be here B option, glomerulonephritis. Whatever is the etiology of glomerulonephritis, IgA glomerulonephritis, a post streptococcal glomerulonephritis, lupus glomerulonephritis, any glomerulonephritis will be the answer here. Now come to question number 11. Okay, so question number 11 was a very new question. Bhuto na bhavishyati. Yeah, that means ki it was not asked in the past, or it will not be asked in the future. So it is just a question which is just out of place. But smart students can rule out the options and make the correct answer. So this is a question where taking a risk will be better than leaving the question. The reason is we know the known names, just rule out the known names, key where they are used. So elderly male with a history of comorbid conditions on multiple drugs, which of the criteria are used to avoid certain drugs in these patients? So to avoid the drug interactions. Duke's criteria is used for infective endocarditis. That we all know. So that is not related to the drug use. Light's criteria is for exudative pleural effusion. So that is also not there. If post streptococcal is there, there may be a infection of skin or respiratory tract, but answer will not change. Answer will not change, then answer will be post streptococcal only. Jones criteria. So the Jones criteria is for acute rheumatic fever. Acute rheumatic fever. So the answer here will be Beer's criteria. Beer's criteria. Now coming to question number 13. Sorry, this was 11. So come to question number 12. Question is which of the following drug is least useful in the management of a patient with thalamic Dejerine syndrome? So thalamic Dejerine syndrome is the sensory symptoms. Sensory painful symptoms due to thalamic involvement. Due to thalamic involvement. Please explain the Jones criteria. The Jones criteria are the criteria for rheumatic fever, major, minor, essential. Major criteria, Jones criteria, all of you can easily understand by this one. Jones criteria, major criteria. This is the full form. This is the full form of major 5 criteria. What is J? J is joint pain, arthritis. O is heart shape, that is carditis. Carditis. N stands for nodule, subcutaneous nodule. E, erythema marginatum. J was joint. Joint means arthritis. And S stands for Sydenham scoria. So major criteria you can just remember by the full form of Jones. Full form of Jones. While the minor criteria you can remember as arthralgias, fever, raised ESR or CRP, and increased PR interval on the ECG. While the essential criteria is evidence of streptococcal infection. To prove a diagnosis, you need 2 major criteria or 1 major, 2 minor criteria will be needed. Now, moving on to the question number 12th. Question number 12th is sensory painful symptoms are there. So, for the sensory painful symptoms, the drugs which we use are pregabalin or gabapentin, tricyclic antidepressants, anti-epileptic medications like carbamazepine. So, all these drugs, including pregabalin, they are used for a sensory painful symptoms, while aspirin is not used for the sensory painful symptom. Aspirin is useful for inflammatory pain. So this is for inflammatory pains. So answer is A option here. Now come to question number 13. So the question number 13 is, which of the following is correct about the Wolff-Parkinson-White syndrome? So Wolff-Parkinson-White syndrome is characterized by the most important feature in the ECG is this PR interval is short. PR interval is short and the QRS is wide with the presence of delta wave. These are the important features: PR interval short, QRS wide, and delta wave. So those students who have done the DFX workbook of medicine, so you can correlate now. Almost all the question come from the DFX, including this Wolff-Parkinson-White syndrome that is asked here. So here PR interval is short, there is a slanting of initial QRS complex. This initial slanting of the QRS complex is known as the delta wave. PR interval will be short and QRS duration will be wide. So see what is given in the option. Answer is broad QRS interval or QRS width. That will be the answer. So short PR interval is not written here. So therefore PJ interval is from the P wave to the J point here. So that is not shortened here, that remains normal here. Question 14. A 70-year-old patient present with a low back pain, KFTs are deranged. So let's see, kidney functions are abnormal and gamma globulin levels are increased. Gamma globulins are the antibodies and spine X-ray shows lytic lesion, multiple lytic lesion. So this is one of the stat question which come, and multiple myeloma is the favorite question whether you are giving FMGE exam or some of the student who are preparing for NEETPG or INICET. Multiple myeloma, one question is asked, direct or indirect question, always in every exam. So this is an important topic. So the cell origin is plasma cells. So what is the clue going in favor? Gamma globulin level increase and lytic bone lesions are present here. In Wolff Parkinson, the lesion is between SA node and the AV node. So the lesion here is the accessory pathway. Like this is a AV node, this is bundle of his, this is right ventricle, left ventricle, and above is atria. So there is a accessory pathway. This accessory pathway joins the most commonly left atria to the left ventricle muscles. So it is bypassing the AV node. That is bundle of Kent. Bundle of Kent. Now come to question 5. So all of the following will show the hypokalemia. If you have some of the student, if you have a DFX workbook, look at the kidney section, and in the kidney section there were only 3 pages, and all the question of the kidney come from these 3 pages. So you can cross check for making a diagnosis of renal tubular acidosis, the serum potassium was taken, and if the serum potassium is low, you can recall back, revise here, urine pH more than 5.5, it is renal tubular acidosis type 1, less than 5.5, it is RTA2. So low potassium. While if the potassium is high, there is only one answer, that is RTA type 4. So here what is asked? Which of the following will show hypokalemia except? So RTA4 has high potassium. So even if you do not know what is ureterosigmoidostomy, so there is no issue. You can make a correct answer here. That is known as the smartness. So examiner check the smartness. Examiner check your smartness even if you do not have full knowledge. So though ureterosigmoidostomy is the loss of the bicarbonate, and that leads to hypokalemia. Metabolic this thing is produced, loss of the bicarbonate here. So the answer is RTA4. RTA4 will be the correct answer here. Now question number 16. Explain the topic of hypokalemia. So topic of hypokalemia, what you can do, you can, because the topic of the hypokalemia will be so vast that it will not be able to cover in such a short span of time. Now child is brought with a 2-week history of not feeding well and excessive irritability. History of TB in the sister is present, so close contact is there. Lumbar puncture was performed. Which of the following is likely to be found in the CSF? So the student who have just gone through that DFX workbook, there was a table of different causes of the meningitis with their features in terms of glucose values, in terms of the cell count, in terms of the protein values that are given: bacterial, viral, tubercular. So these 3 causes. So in cases of because this is a case of most likely a tubercular, so the answer here will be lymphocytosis will be there, not the neutrophils. Neutrophil are bacterial cause. Now coming to what else is common, high proteins is seen in tubercular meningitis. So the only thing which is left here is the sugars. So tubercular bacilli consume the sugar. So low sugar will be there in the CSF fluid because it is consumed by tubercular bacilli. So answer is A option here. Yes, RT type 4 is the second name for hyperkalemic tubular acidosis. Yeah, correct. This is correct. Yes, cobweb appearance. Very good. Now coming to question number 17. 60-year-old man presents with a sudden onset of right-sided hemiparesis for the 3 hours. BP is 220 by 130 millimeter of mercury. I'm not sure about the BP values, so you can tell me or inform me. NCCT head shows a hyperdense lesion. Hyperdense lesion is suggestive of hemorrhage. So patient has got hemorrhagic stroke is there. So all of the following are to be done for the management here, except this is very easy. In a hemorrhagic shock, why should you go for a thrombolysis? So it is absolute contraindication. So answer is thrombolysis. And BP control in a hemorrhagic shock is advisable. It is advisable when it is more than 220 by 120 millimeter of mercury. In that case, we will try to reduce the blood pressure. Edema management, hyperventilation, they will decrease the intracranial pressure. That will be done. Done this question wrong? No, this is yes. There might be a chance ki BP control should not be done and thrombolysis out of these two choices. So this is very important ki contraindicated thing is thrombolysis. So that you should mark if you are doubt in the BP control. That can be the issue here, because if the BP is given like 180 by 100 or normal BP 140 by 90, like that, if these values are given, so in that case BP control is not needed for hemorrhagic stroke. So but if we have to pick the best option here, then contraindicated will be thrombolytic therapy. First we can go for BP control, then the shock management. So if BP is high, there is no shock. So these are contradictory things, high BP and shock. Edema managed by mannitol. Yes, edema is managed by giving mannitol, edema management. Now question number 18. A 60-year-old patient diagnosed with acute ischemic stroke. So, as I told you, many questions come on the stroke. So, if you open the page number 1 of DFX, page number 1 is on the stroke, contraindication of the stroke, which agent is to be given. So, that is page 1 of DFX. So patient with acute ischemic stroke, thrombolysis is done with alteplase, weight is 80 kgs, how much dose in milligram should be given stat. So the dose which will be given of recombinant tissue plasminogen activator, it is given as initial dose which is given as 10%, that is bolus. 90% is infusion, that should be given, and the total dose which is calculated is 0.9 per 0.9 milligram per kg body weight of the patient. So it will come out to be approximately 8. It will be coming out to be approximately 8 in this scenario. Now, question number 19. Question 19 is, in a patient with chronic dialysis with dementia, which deposit is seen in the cerebral cortex? So, slightly tough type of question, not a straightforward question. So how can we solve this question? We can solve this question as ki dialysis membrane does not filter out beta 2 microglobulin. So the amyloidosis which occur here in a chronic dialysis patient, amyloidosis which occur, it is a beta 2 microglobulin amyloidosis. And the most common site of deposit or characteristic are joint, bones. These are the most common site of beta 2 microglobulin amyloid deposits. So the best option we will go here will be beta 2 microglobulin that will be deposited. Whether they are deposited in the cerebral cortex, it is not as such mentioned, but the best option out of all these will be A option itself, because beta 2 microglobulin amyloidosis predominantly affect the musculoskeletal system. it a predominant effect, but there is no other option. Like it is not macroglobulin. Transthyretin is a familial amyloidosis due to a mutation of transthyretin in the liver, and predominantly it affect the cardiovascular system. So we can rule out. Both peritoneal and hemodialysis can't filter beta 2 microglobulin. Yes, that is a correct explanation here. Correct. Okay, now coming to question number 20. Which of the following will help in making a definitive diagnosis of bronchial asthma? So the definitive diagnosis of bronchial asthma is equal to obstruction, mandatory plus reversibility. These 2 points for bronchial asthma: obstruction plus reversibility. Reversibility after beta 2 agonist, the FEV1 should increase. So the answer here will be best option. Reversibility is given. Patient history, it can be confused with the cardiac asthma also. It can be a COPD also. Focal wheezing sound is suggestive of a localized lymph node compressing the airway or localized secretions causing a airway narrowing. HRCT, no, bronchial asthma diagnosis is not on HRCT. HRCT is best for making a diagnosis of bronchiectasis in obstructive airway disease. Yes, airway disease, bronchodilator increases the percentage of FEV1. Correct. Some books you will find 15%, and some books take 12%, more than 12%, as the criteria for reversibility. Now question number 21. So question number 21 is patient has an road traffic accident, brought to the emergency with bradycardia along with high blood pressure. Glasgow coma scale checked and it came out to be less than 8. So GCS score is less than 8. That means patient has altered sensorium, patient is in coma phase. So the first step in any patient who is in severe altered sensorium or in comatose phase is always secure the airways. Then we will check for the metabolic parameters, then we will check for the CT scan, and then we'll take a decision accordingly. But the first priority is airway secure. That is most important. Yes, correct. Now question number 22. Question number 22 is antibody seen in acute inflammatory demyelinating polyneuropathy. This is a autoimmune disorder. The most common infectious cause is Campylobacter jejuni. And after a duration of 4 to 6 weeks, patient have autoimmune damage of the nerves, and the antibody which will be present is of IgG class, will be the antibodies. Looking for cervical injury or not? Yes, cervical injury is mandatory to be ruled out. And why cervical injury is important? For airway, because the nerve, phrenic nerve is going through the cervical. So if neck stabilization is not done, then it will cause the permanent damage of phrenic nerve, and the respiratory system will go. So what is that? Cervical stabilization will come under which group? Airway secure automatically. Now come to question number 23. Again, this is a question on the reversibility. So here the best answer will be more than 12. 15 is not given, so 12. Now question number 24. A 65-year-old man is brought to hospital with complaints of suddenly not making any sense while speaking, using a nonsensical grammar. Though he can speak quickly, he could communicate effectively prior to that. So that means it is a acute episode of the language disorder. Language disorder. So, in the language disorder, if it is a Broca's aphasia, the most important thing is fluency will be lost. It is a motor aphasia. Fluency will be there while comprehension is normal. Comprehension is normal. In anomic aphasia, only naming is disturbed. Fluency normal, comprehension can be normal. Wernicke's aphasia. In the Wernicke's aphasia, fluency is normal, comprehension is poor. While in conduction aphasia, in the conduction aphasia, fluency is normal, comprehension is normal, repetition is gone. Repetition is gone. So for the aphasia, for a simplified aphasia, because one question usually come here, you can watch the YouTube channel Dr. Arvind Kumar. This aphasia topic is there in a very simplified form. You can watch to make your concepts clear. Dr. Dash Arvind Kumar. Now, coming to the question number 25. So, question is, patient presented with pedal edema, raised JVP and ascites. So, what is the most likely diagnosis here? The most likely diagnosis in a patient of pedal edema, raised JVP, ascites. So that means it is a sort of a right ventricle failure. Right ventricle failure is leading to ascites, pedal edema and raised JVP. So the best option here will be A option, cardiac failure. Cardiac failure. Now coming to question 26. A patient presents with recurrent episodes of epistaxis, cola colored urine. Cola colored urine is hematuria most likely. Recent workup of hemoptysis shows multiple cavities in the lungs. Which of the following test will help in confirming a diagnosis of this condition? So as I told you, this has been discussed earlier. Vaginous granulomatosis, upper respiratory tract infection plus lung cavity plus C ANCA antibody. So that will make a diagnosis of the vaginous granulomatosis. Now coming to question number 27. So the question 24, Broca's right since his speech was nonsensical. No, in Broca's the speech will make some sense. The speech output will be reduced, but it will make sense. Patient will be able to communicate you with less words. With less words. Now coming to question number 27. Cola colored urine in nephrotic syndrome? No. In nephrotic syndrome, the urine will be frothy like bubbles, proteinuria. Cola colored means RBCs, hematuria. Now coming to the Duke's criteria. Duke's criteria was mentioned earlier for infective endocarditis. So if we look at the Duke's criteria, it will be evidence of infection in the form of blood cultures as well as echocardiography revealing a vegetation. These are major criteria. Now what are the minor criteria? The minor criteria are fever, predisposing cause or risk factors like rheumatic heart disease or IV drug abuse, immune events, vascular events, And major criteria investigation blood culture not satisfying the major criteria. So out of this, fever is present here, minor criteria. IV drug abuse is a minor criteria risk factor, and raw spot is the immune phenomena which is present here. So answer is 3. 3 criteria will be present here. So coming to the question number 28. A 13-year-old girl present with increasing bleeding post dental extraction. Prothrombin time is normal. No history of knee pain, swelling or knee swelling. Which of the following is correct about the diagnosis of this patient? So the diagnosis of this patient, factor 8 deficiency, factor 9 deficiency, hemophilia are given. Vitamin K deficiency, von Willebrand disease is mentioned here. So the best answer here will be the hemophilia. Hemophilia is seen in males, we all know. Prothrombin time is normal, that means ki vitamin K deficiency is also ruled out, because vitamin K deficiency will elevate the prothrombin time. And von Willebrand factor, it help in the platelet adhesions, so that means ki the bleeding time will increase. Bleeding time will increase. So answer is D option here. So von Willebrand disease. Now moving on to question number 29. A patient is admitted with multiple episodes of seizure and serum sodium was 110. Calculate the total correction given to the patient, given to this patient, total correction or total deficit sodium. So the total sodium deficit, total, it is equal to normal sodium is 140 minus patient sodium on presentation 110 multiplied by body water. Body water, it is 0.6 into weight for males, 0.5 into weight for females. So this is the total sodium deficit. So if can anyone tell me, was this the complete question? Was there any mention like total correction to be done in 24 hours? The answer will change then. Total sodium deficit overall is different. Sodium replacement to be given or total correction to be done in 24 hours is different. So just let me know. So if it is a total sodium deficit in this patient, 140 minus 110, so it will be 30. She is female, so we will take 0.5 into weight. So 0.5 into weight, 40. It is taken. So it will come out to be how much it will come out to be. We will apply the mathematics. So 30 into 5 into 4. So it will come out to be 600. So it is come out to be 600. So none of the option is giving the answer as 600. So most likely the question might be total correction to be given to this patient in first 24 hours. So the formula for this is 10, maximum 10 into the body water. 10 into body water. So the body water here will be 20 and multiply by 10, it will come out to be 200. So answer will be 200 if the question is in first 24 hours. Most likely the question will be in first 24 hours ki how much correction should be given in the patient. If it was total, then there is no option which gives the answer as 600. Now question number 30, that is our last question of the discussion. Yes, so what can be given to eat in a celiac sprue patient? So celiac sprue is due to bro diet. So they should not be given. B stand for barley, rye, oats, wheat. So these should not be given. So oats, rye, wheat is not given. So we will give rice to the patient. So that is the correct answer here. So this was the question discussion of the FMGE exam, and overall it was a moderate to slightly tough side exam, but with smart practice of the MCQ, you can solve these questions easily. Those students who have already done the MCQ practice and who have done the DFX, so 90% of the question now you can also cross check were from DFX workbook. So with this we will finish with the session, and all the very best for your results. Best wishes always.